generally fare worse in terms of their physical health. So having those annual health checks is really critical. I won't go through the next few slides in detail, but there's just some particular developments. But I do want to highlight during the year, Cheswold Park, which was a medium secure mental health facility in Doncaster, which was in private ownership, came back into the body of the NHS Kirk, which is really positive because it was at risk of closure. It's now stabilised and moving forward. So I think that's a really positive thing to mention. So well done, South West Yorkshire Partnership Trust. Just to pick out a few other developments, £7 million investment in additional capacity in the Rotherham Hospital, Doncaster, £20 million programme to improve its critical care facilities. But I would point out that we still remain concerned about the general quality of the state of Doncaster and the risks that presents. Just moving on to tackling health inequalities, neighbourhood health is a really important focus for us. So really pleased that we've made good progress. So whether that's the North East neighbourhoods in Sheffield, or the health on the high street in Barnsley, or the family hubs in Rotherham, it's really good to see that Rotherham and Doncaster have been identified to be part of a national programme to really accelerate progress in the development of integrated neighbourhood health. So I think really positive there. I guess just some other comments about improving access. The diagnostic centres at Barnsley and Mexborough have gone from strength to strength. We've got a second phase happening in Barnsley with the Alhambra development, and we're looking at something similar within Doncaster. VCSE remain a really important partnership. I've mentioned the relationship with Work and Health, but as a really good example, we've launched £600,000 worth of community grants, working closely with the voluntary sector to try and support people to stay in work or return to work if they have a health challenge. We work really hard to make sure that we listen to the people that we serve. So I would draw your attention to one, we've also published an involvement annual report with lots of examples of how we're working closely with our communities, but also the development of the new citizen involvement strategy and the Insights Bank, which is basically using all of the intelligence that we're gathering from the 1.4 million souls that rely on our services to help shape their future. Just a couple of examples of innovation. I won't go through those, but there's a lot of really good stuff happening, which you can read in the report. I've mentioned the ICP. I will just say a little bit more about that relationship between work and health that I've touched on. But one of the things that we've done collectively with the Mayoralty and the 4 local authorities is secured £18 million worth of investment to enable 10,000 people to either to stay in work if they have a health challenge or to be supported into work, because we know that being economically active is a really important part of living well and staying healthy. And again, just a couple of other examples. We're also working with the Mayoralty and Sport England to see if we can align our various programmes of work, again, to promote not just sport, but generally just more activity. Because again, being more active is a critical part of being well. So I'm kind of going to pause there. I will hand over to Lee. We'll have an opportunity for questions, I guess, from the public later on, but I guess we'll take those at the end. But Lee, do you want to cover the finance?
Thanks, Gavin. It would be remiss of me not to say it's been another tough year financially, but I grow slightly weary of saying that year on year as a CFO in the NHS, but it probably happens to be true. Probably looked at from a longer term perspective, just the kind of nature of the austerity decade, 2010 to 2020, when the NHS had a lower level of funding growth than it had done historically, then just the shock of the COVID period. It still feels a little bit like we're coming out of that as an overall system and service. In terms of bold numbers, however, in terms of what happened in 24-25, as a system, we originally planned with our 7 hosted statutory provider organisations to have an overall deficit of 49 million. Halfway through the year, some money was made available to the provider side to sort of deliver that a break even for the provider side, but notwithstanding that additional money that came in for the providers, we still overall made a deficit as a system of about 30 million quid. And the biggest proportion, well, a disproportionate amount of that was hosted at the ICB end. So in terms of addressing financial planning for 25-26, we've tried very intentionally to talk about how do we make sure we've got all the financial risks housed in all the right places across the NHS system. We're accountable as an ICB not only, however, for our own financial performance, which you can see there, we did not manage to deliver a break-even plan. That resulted in a Secretary of State referral letter saying we did not achieve our break-even plan because we have a statutory duty to break even. We're trying incredibly hard, however, this year to get to a break-even plan overall as a system. And our provider organisations and ourselves are still on plan in terms of 25-26. We didn't manage to deliver financial balance and our statutory duty in 24-25, however. However, we are now exactly halfway through the financial year. So even though we're looking back in terms of the annual meeting, probably quite important to look at what's going on in terms of the 25-26 plan. We're in receipt this year of 71.4 million of deficit support funding as a system, which enables us to get to a break-even plan. Our planning approach in 25-26 was even more collaborative than previously, and we had an agreed set of principles about how we planned as a system and in a transparent way. However, there is still an enormous savings requirement we've got as a system in 25-26, representing around 258 million of a total ICB turnover of 3.8 billion. So that's 6.9% of the total allocation, which happens to be the same average savings requirement for all the integrated care systems across England. Last year, we had a savings total of 7.1% of total turnover, which was slightly higher than the national average. Perhaps a crumb of comfort amongst all the despair is we've got a slightly lower and more average savings target as a system in 25-26 than we had in 24-25. We're currently doing an enormous amount of work as an ICB in terms of delivering the best financial performance we can, in terms of there's an assurance subcommittee of the board now dealing with turnaround, a weekly turnaround group to make sure we're getting good value from every pound we spend as an ICB. And we're currently doing lots of work with NHS England to try and ensure we can deliver as good a financial performance as we can and that break-even position by year end. But happy to stop there and happy to take some further questions.
Thanks. So we won't take questions till the end of the day. We'll go on with our presentations. We're going to start with the 10-year plan, and the first bit of that is about hospital to community shift. We've talked about a lot. Anthony Fitzgerald, our Executive Place Director for Doncaster and lead for primary care, is going to talk you through what we're doing. Anthony, do you need the...
yeah.
Don't let me touch you.
Right. Morning, everybody. Yes, the hospital community was one of the 3 shifts advocated within the 10-year plan. What I'm also going to talk about is neighbourhood health. As Gavin's already alluded to, we are right at the forefront of this work nationally, but it's not new to us in South Yorkshire. This has been our direction of travel for quite some time. So, there is quite some debate about what is meant by neighbourhood health, and there is a lot of debate nationally on how it should be implemented, how it should be contracted, what population base is a neighbourhood actually referring to. But actually at its heart is the quote there. It's providing care closer to people's homes, helping maintaining independence, and only using hospital where it's clinically necessary to do so. And of course, there's a lot nationally, only today, isn't there, about digitally enabled hospitals and the future of the future of that agenda. So what we'll see over the course of the next years is greater or different investment in out of hospital care and creation of neighbourhood health services with the intention of improving our access and delivery of more urgent emergency care in the community. But as I say, this isn't new to us in South Yorkshire, and we've great examples across our towns and cities how this is being implemented, and the board has seen many stories throughout the year of examples of those. So just to quote a few, and I don't always start with Doncaster, but I will, is that we have, for example, a Doncaster health van that's run by our public health, our primary care and our voluntary community teams. In its first year, it's visited over 38 locations in Doncaster. It's provided 2,000 GP appointments and over 100 screening appointments for cervical or liver checks. So this is good stuff. It's going into our communities that need it the most. Rotherham, the proactive care model is a great example of social prescribing and how non-medical support can improve health and well-being. And the case studies that we see back demonstrate how interventions have improved people's mental health, housing stability, social connections, physical well-being, and independence. So this non-medical model that we've got in Rotherham is going great guns. Gavin's alluded to the Sheffield This Is Us north east model, and at a very hyper level, I was really struck by a story around an Eritrean lady who had escaped domestic abuse and homelessness and was supported by housing assistance, tailored well-being activities, mental health support, and that had given her real renewed hope and active community involvement and progress towards employment. So there's really people-centred work that is going on there. And of course, the jewel in our crown, Barnsley Health on the High Street, it's real. I've walked around Barnsley Health town centre, and there is a buzz around it, and bringing the health into the high street has been a big part of that. And we've got great plans to expand that further, haven't we? So what will the future look like? I think it's great that we're part of these national programmes in Rotherham and Doncaster, and that will give pace to the work. But actually, the pace is equal in Barnsley and Sheffield in terms of that. I think there's a few things that we just need to be careful with this. It's great stuff, but it's not without its risk. And at the heart of that, I see that we need not be distracted by a one-size-fits-all to neighbourhoods across South Yorkshire. When talking about the definition of what a neighbourhood is, it's actually the residents who will tell you. They know who their connections are. They know the things that they need the most. So we can't be distracted by a kind of one-size-fits-all national programme to that. The other risk, following hot on Lee's tales, there is no new money for this. This is about using our money differently, and we've got to be innovative and imaginative on how that's done. And of course, our role as an ICB will change. In our part at the moment, we are very much the system convener and leader of bringing partners together on this. We need to be ready for the new climate when it won't be us, and we need organisations coming together to really drive the work. This is an exciting time. There are some risks to it, but it's right at the heart of what we've been doing in South Yorkshire anyway.
Thank you. Barbara, are you next? Or is it Kieran? Kieran, hiya. I'm definitely not going to touch this with you.
Might be able to work. Morning, Kieran Baker, Chief Digital Information Officer for the ICB, and I've just got a couple of slides to give you a bit of a taste of what the 10-year plan talks about in terms of digital first care. There's quite a bit in there, but I'll just stick to the key messages. So obviously we know the NHS app has been around a while. It was massively accelerated over COVID times, but there's quite a big vision to further expand that. Sort of trying to make that the real front door, the central starting point on entry to the NHS, so you can access your information, you can access the ability to book appointments, you can already request repeat medication. There's additional things in there, so talk about My Carer, so it's about managing the care of loved ones, of children as well. So there's a really big aim to expand the NHS app. Linking into that is information. You know, we all know that it's an incredible challenge when you go and see a healthcare professional. You've got to tell your story again, then you see a different one, you've got to tell your story again. The single patient record aims to try and resolve that by having a single comprehensive set of information about you when you visit your healthcare professional, so that you only have to tell your story once. And that'll be the single authoritative record that you as a patient as well can access yourself and make sure is accurate and is representative of you. The third part is digital by default, or digital first, as they talk about in the NHS. So this is trying to expand the ways in which patients can get access to services through remote consultations, online consultations, and we all know there's been quite a bit in the news recently about general practice in particular, around people wanting to get access to their GP through online means by booking appointments, etc., through applications. So that's been called out as well in the 10-year plan. Bit of a buzzword at the moment on everybody's lips is artificial intelligence, AI. It's everywhere now. So the NHS has quite a big vision of using artificial intelligence to really improve productivity within the NHS by using intelligent scribes to record consultations, to make communications and correspondence much more efficient, to save our health and care staff from having to input information into systems. Hopefully the AI tools will be able to do that, but also to reduce admin burden as well by automatically undertaking routine tasks, just to reduce the burden a little bit on some of our health and care staff and make them, I guess, give them more time to spend time with patients and to deliver care. So this is the first bit, just give you a high-level overview of the 10-year plan. I felt it important as well just to give you a bit of an overview of where we are in South Yorkshire in terms of underpinning some of these capabilities. So there you go. The strategic vision, so we have a number of strategies already for South Yorkshire. We've worked really hard to put together a very collaborative and collegiate digital transformation strategy. We've got a data and insight strategy that's already in delivery. Cyber is really important. We need to protect our services. And again, I think there's been more in the news about commercial companies being hit with cyber attacks. So we really do need to protect our health and care services. And of course, we need to build digital literacy into our health and care workforce as well. So we've got a strong digital workforce and skills strategy as well. And all these are just going through final proofing before being published on our ICS website. Talked quite a lot on the previous slide about NHS app, digital first care. But actually, we need to bring people along with us. We need to make sure our communities have got that support. They've got access to devices and even Wi-Fi and internet, which some of them don't. So it's really important that we have a strong digital inclusion programme, which thankfully we have in South Yorkshire. We've partnered with the Citizens Advice Bureau, who work across all of our 4 towns and cities to really support people in accessing support to get the best out of digital services. And I think that's a really, really important agenda that we must try and continue. Mentioned cyber, we've got a really good collegiate cyber forum in South Yorkshire where hospitals and local authorities come together to share skills, capabilities and to work together to improve our defences against cyber attacks, and we're going to continue doing that over the next few months with some investment from NHS England. In terms of the single patient record, we are already working quite hard to implement the shared care record across South Yorkshire, and that is essentially the South Yorkshire version of being able to have a single comprehensive record about you as a person when you go and visit your hospital doctor or indeed your general practitioner. So we're working really hard to do that. We're also working with the national team on adopting the federated data platform, which is another way in which we can use information to really better understand the health and care needs of our people so that we can better tailor and develop and design pathways and services to meet those needs. So working really hard on that, and Barbara will give you some additional statistics around our population shortly. Then the final bit is, we've got an ambition to be innovative, and that's no different in the digital space as well. We've got a really strong innovation hub, which is all about partnership. It's about bringing together commercial partners, academic partners, voluntary care sector and health and care to really come up with some good ideas and some innovative solutions to address the needs of our population. And we've got a good track record over the last few years of bringing in novel digital solutions, for example, making them available to all people across South Yorkshire, and then working with the services and the providers to evaluate them, to see if actually they're providing us with the gains and the benefits that we expect. So hopefully you'll have seen a bit about the 10-year plan and a bit of how South Yorkshire is equipped and is already delivering some fantastic capabilities to underpin the vision of the 10-year plan. I think it might be. Barbara.
Thank you. Hi everyone, I'm Barbara Coyle. I head up the Data and Insights team in the ICB. So I'm going to talk a little bit about why it's imperative that we move from a sickness and treatment model to a prevention model. And because I'm data, I'm showing numbers. Sorry. So why? Well, at the moment, sickness and ill health in South Yorkshire is costing us too many lives. On average, we are living 1.5 years less than if we lived somewhere else in England. That is not acceptable to us. Also within South Yorkshire, we know we've got huge discrepancies between those who are living what we call our sort of most deprived areas, who are living about 9 years less than people who live in other parts of South Yorkshire, which we describe as more affluent. So these aren't inevitable. We can do things, we can make changes in that. And as you can see from the chart, the gap between us and England has actually increased over time. So we need to start thinking about what are those causes of those discrepancies that we've got. One of the main factors is it's generally accepted that what causes our health, only about 10 to 20% of that is actually related directly to the healthcare we get. The rest of it is about the environment, our behaviours, and are we living in those areas that have got good access to assets like a good job, a good living condition, a good wage, a good education, a safe space to be. So, and at the moment, we know 37% of our population are living in those areas that don't have those access to those resources. So that's the challenge that we have. We also know that the burden of disease is changing, where we are living more years in ill health. But a third of our population are living with at least one long-term condition. So we're no longer sort of treating people and fixing them and sending them back to their environment. They are living with ill health. And all that that entails. The most sobering statistic I heard recently from the Health Foundation, who's predicted that in 2040, 15 years' time, we will see a 25% increase in our working age population that are living with a long-term condition. Think of all the knock-on effects that has between being in a carer, looking after your families or working. So a huge sobering statistic. And will the NHS funding match that 25%? I doubt it. So this is the bad news. The good news is we can do something about this. We can do prevention. We can prevent people from getting ill. So one of our big killers in South Yorkshire, let's call it an early deaths in South Yorkshire, are things like, it's only a smallish number of conditions. So it's CVD, cancer, respiratory and liver disease. If we add in MSK and mental health, they are also the reasons why we are living in poor health. So it's the day-to-day living in health as well as what we're dying with. So it's only a relatively small numbers of things that we have to control and manage. And interestingly, all those conditions, including MSK and mental health, have the same risk factors. Things like smoking and poor diet, obesity and high blood pressure. Now, at the moment, we've got about 14% of our population smoking, 67% overweight or obese, and 18% report that they binge drink. Now, these are dials that we can support people in changing. That we can do things about these. These are all modifiable risk factors with support and help, bearing in mind those wider determinants that are helping to create those environments. So the things we can do. So that's one of the first things. Secondly, we also know it makes sense to prevent because it will save money and it will improve a person's health. So things like improving blood pressure management to treat to the nice standards. If we've got all our patients that we know with hypertension, measured their blood pressure, got them sorted, we will be saving over 270 strokes, 185 heart attacks in just the next couple of years. That then also saves about £3 million. We can do this by being in places where people are. So we've heard from Anthony about all the work in the neighbourhood models, How's Thy Ticket campaign in Barnsley, going to where people are, doing their blood pressure checks, getting them seen early. Cancer survivor times are much, much greater if you get them early. That saves lives, it saves money. So we've got more to do, and we know that, and we've got the South Yorkshire Shows Up campaign to help us get those cancer detected much earlier. And then thirdly, if we work with our partners and those environments that create health and do what we can in that space, like work and health, we can stop people getting ill. Health and work, for every 10% increase in an area's employment rate, we see a healthy life expectancy by 5 years. It's good to be in good health and it's good to be in work if you're in good work. So there's lots of opportunities there for us to do something about that. Fortunately, at the moment, so many of our people who are economically inactive, more than half of them are inactive because they're in ill health. So if we can do more in the NHS to prevent that from having to leave work, it helps us get to that cycle where we can actually improve our life expectancy and get us above that England rate. So they're the sort of three simple areas and the three spaces that we can be in to prevent ill health. That's me.
Thank you. Barbara, thanks. I hope you enjoyed that. That was meant to be a bit of a run through of what we're trying to do under the NHS plan and some of the long-term issues affecting us. I suppose the takeaway from that is actually we can make a difference here. It's difficult, it's long-term, but we can make a difference. And I thought that the theme of that's really important. Okay, I'm now happy to have questions, including questions online from members of the public. So will you keep me in the loop if there are any? Anything from the hall? That's great. Anything online? Yes. Okay, I'll leave it a minute or two, and then before we close down. Is that all right? As it comes through, give me a shout. Great. The stunned silence is normal in an annual meeting. I need to tell you, at my age, I've done a lot of these meetings, and this is quite normal. Moira.
I'll just ask a question. I'm Moira Wilson, one of the independent non-execs. It'd be interesting just to hear a little bit more about the Rotherham and Doncaster proposals for the
neighbourhood health.
The neighbourhood health. Just a
Okay.
bit more.
No,
about
I think
what
that's
the
helpful.
plans are.
Why don't we ask both place directors to give us a sense of that proposal? Chris, can I start with you, given that Anthony's already spoken. Chris is Rotherham place director.
Sorry, shall I stand up? So, I'm Chris Evans, I'm the place director for Rotherham. So, the Rotherham and Doncaster pilots are slightly different. So, the Rotherham one's particularly focused on moving from hospital to community, to treating patients out of hospital. And just to give a flavour for how it works, we've got people from every sector across Rotherham will be engaged in workshops with people across the country trying to share best practice and work through. And then what we'll do is we'll come through and try and implement back into Rotherham and then share across South Yorkshire. But it's particularly focusing on frail elderly patients, CVD patients, so cardiovascular patients, and maybe probably because Rotherham's industrial past will probably move into respiratory patients as well. So that's sort of the headlines for what the project's about, Chair.
Thanks.
Yeah,
Doncaster.
yeah, so subtly different, but slightly the same. The idea of the programme, Moira, is that it concentrates on people with 2 or 3 multi-conditions, if that makes sense, because, well, Barbara, you've shown us, haven't you? You know the data there says where that affects our people the most. Subtly different in Doncaster, we really want to give it a mental health focus. We know that we have high cases of urgent mental health care needed in Doncaster, but also a sort of big cohort of people not diagnosed with mental health issues, but we continually find when we talk to our public that social isolation, depression is a big issue for our residents. So we want to give it that kind of theme, and our mental health provider and our voluntary sector organisations are deep in those conversations already. Just a little bit to add, Chris, from how the national programme is going to work. So I did subtly hint that we are 2 of 43, I think, across the country. Actually, in the north, in our region, we've got 7. So we've got a real focus on the work that we're doing. It doesn't come with money as such, but it comes with expertise and support from national coaches to help guide us through this kind of work. And what I'm also hoping is that it comes with a bit more pace and expertise around how we can contract around neighbourhood health, and how we as an ICB can incentivise organisations to work together for improved outcomes. So it's early days, but that was why we were so interested in being in the programme. We will not be leaving Barnsley and Sheffield behind because they won't let us, because of the great work that's been going on already. But the shared learning is a big part of this programme, so we'll make sure that we do that.
Thank you.
And I guess the big issue for me about all of these presentations this morning is that we ran an NHS since 1948, which involved when people presented to us, we tried to sort them out. You had to present to the GP, the A&E, or an outpatients department. What that has left us with is too many people presenting late and lots of people living longer because we've been more successful keeping them alive with multiple conditions. And they are always associated with deprivation. If you like, the next 20 years, it strikes me, about reaching out into communities to get that early, either in prevention or early treatment, rather than waiting for them to arrive at our front door. And that's something we are having to reconfigure the whole NHS to do. The NHS has largely been about, you come and see us and we'll treat you. That was probably okay in 48. It clearly isn't right in 2025. And all of these changes, in my view, are about that more than anything else. Leslie, you wanted to come in.
Yeah. Can I just ask a question about the move to digital? Because I think there's a lot of anxiety in communities about that move to digital and the risk that we can leave people behind and that actually we can create inequalities of access as a result of that move. And I just wonder if, Kieran, if you've got any thoughts about that.
Yeah, thanks. I think just to reiterate, I guess, the point that I made earlier, that it's really important that we bring our populations along with us, but also we don't move everything digital. We maintain a strong focus on offering in-person consultations, in-person services where it is needed and where people prefer that to be the case. So I think it's better to use digital as a supplement to in-person consultations as well, but equally where digital services are available, we bring people on by offering them support and guidance. And as I mentioned earlier, the work we do with Citizens Advice Bureau to roll out support across the entirety of South Yorkshire, access to devices, access to Wi-Fi and internet, access to drop-in sessions so that we can teach people how to use the NHS app. All these things need to be in place so that people can best utilise those digital services. And as time goes by, people get more au fait with them, which will hopefully mean that you might see a slight shift towards an increased uptake in digital services over time. But certainly we need to use it as a supplement and maintain a core of in-person services as well.
I think there's something as well about making them really easy to use. We all use digital platforms, whatever ones they are, all of us. And sometimes you're on one and you think, this is fantastic and it works really well. And other times you think, I'm in this loop and I can't get to what I want to do. So there's something about making it digitally accessible, giving people a chance to use devices, but there's something about making it really easy to use. Amazon are successful because they make it easy to use. Actually, so it's got to be that straightforward. I do this, I access it, I come back and I think, actually that was easy. So it's not about digital, it's about making it really convenient and easy to use. And that's not always the case because we all use other apps where you think that was a pain. Kieran.
Yeah, thanks, Chair. So just, I guess, one bit to add on to that, particularly the NHS app and specifically all government services really, there's a national government design toolkit which essentially dictates how digital services offered by the government should look and feel. So anybody who's filled out the census, you'll notice it's the same process and looks the same as when you're taxing your car or doing other things. And that's because they've got a consistent design approach to it. And that takes into account all the latest research around accessibility, around user-centred approaches to using digital tools. So I just want to say that work is ongoing with the national team in development of the NHS app, so they're taking all that into account.
Yeah, let me give you an example. A friend of mine, a good friend of mine, their father died recently. And they had to kind of start registering stuff like that. And she said it was so much easier than it was 10 years ago. There was one point, and it then notified everybody, it notified pensions, it notified. And actually, that's what you want, isn't it? It's so that I just do that, it takes up automatically. Anthony, you want
it's a real timely because I'm sure people have seen in the news today, big headline about the ability to book online consultation within general practice. A couple of things to say that's relevant to your question there, Leslie. First of all, we've had this in operation for quite some time in terms of that this is now contractually a requirement for all practices, but we're well on our way with South Yorkshire to do that. But the word we're after, I think, is appropriate. So when it is appropriate for patients to have an online consultation, we can facilitate to make sure that that's the case. That does not replace the ability for people to ring up and book an appointment, indeed walk into many places and have an appointment, and it doesn't replace face-to-face appointments where it's appropriate to do so. As Kim says, this is an aid to help with that demand and capacity that we have, and everybody's heard of the 8 a.m. scrum, haven't they? General practices. This is an attempt to help with that kind of pressure.
Thanks, Alison. Any other questions? Nothing online?
No.
Okay, at that point, 10:15, you've got 15 minutes of your life back. We will finish the meeting now. Thank you very much. Thank you for all the presenters. For the board, the informal session, take a break, have a drink, and that's coffee, by the way, and tea. We'll start at 10:30 rather than 10:45. What we're doing, just so that you know, I thought it was a bit of a pain to rearrange the table, so we're going to do the next session of the board in this format, if that's okay. Thank you very much, and that's the end of the meeting. Thank you.